And letting all these beautiful ladies that are sitting. You have drawn quite a following, Dr. Rockhead. I am
Yes.
very impressed. Very impressed. My goodness. So, Menopause Monday. Welcome, Dr. Rockhead. Hi, Nats. Happy Monday to everybody. This is going to be a great episode. We're so excited to have Dr. Rockhead on with us today. So, I'm just going to do a quick bio because we don't want to hold him too long. We have tons of questions, and I know all the ladies that you have drawn here this morning have some amazing questions. So, Dr.
Absolutely.
Charles Rockhead is a highly respected consultant gynecologist and obstetrician with nearly 30 years of experience in women's health. You're based in Kingston, and you're known for your expertise in gynecological and obstetric care, minimally invasive procedures, and, of course, cosmetic gynecology. So you offer a wide range of services, which I think is awesome, from general gynecological care, which is like endometriosis, fibroids. You also do menopause and bioidentical hormone therapy for male and female, intravenous hydration, nutrition, fibroid treatment, cosmetic gynecology, fertility counseling, and reproductive health. I mean, this is amazing. When I read your
Wow.
bio, I was like, whoa, this is amazing. So, welcome, Dr. Rocket. It is such a pleasure to have you on today's episode.
Thanks for having me. Thanks for having me.
Absolutely. We've been doing this for almost a year now, and the feedback that we get, Nikki this morning just got an amazing phone call from someone who's basically, I would summarize to say that she basically said that we're saving her life. Basically, is what she said. Like she's now learning so much that she didn't know before. And this is one of the challenges that we face with menopause is it's been such a hush hush taboo subject for so long. Our mothers didn't talk to us about it. Our grandmothers didn't talk, so we're coming up on this age and stage of life where we feel like we should still be young and vibrant, but we start to feel a little pop down. All sorts of things start to go awry, and we really just want to give a voice and information to the women. Now we've had conversations with doctors about HRT before, but there's so much to cover when it comes to menopause. That's why we wanted to do a bit of a deeper dive. I think there's also the feeling in Jamaica that there's no local affordable options available to women, that a lot of foreign expensive therapy treatment, that kind of thing, so it becomes almost prohibitive for some women to access. What has been your experience in your practice when it comes to women and treating signs and symptoms of menopause?
You know, Natalie, you've kind of struck the nail on the head in that menopause has been such a taboo subject for so long that we are now, what I'm happy that you guys are doing is creating a platform so we can educate, we can speak, we can consult, and we can talk. Because talking is important. It's not a vertical conversation, it's a horizontal conversation. So on that note, I'm just going to give you a backdrop as to why menopause is such a big issue now when it wasn't before. So up until the 20th century, the average lifespan of a woman was in her 47 years old in the 1900s. So they never lived long enough to have this issue of menopause, because by the time they got to about the time where the climacteric, which is the start of menopause, is, they would be dead just because of the natural history of life back in the day. So with the improvement of healthcare, a woman now has now added 30 years onto her life. And now women are now experiencing these symptoms. And medicine now is trying to catch up with all of the complications, the side effects, or the effects that are happening to women, wives, mothers, grandmothers. Women are also now, in terms of financially, a very big part of providing for their families and their grandchildren. So now they're better able to take care of themselves. They don't have to sit back and wait on a man to say, "But can you give me this money? This is happening to me. I need to go to the doctor." and she
Right.
can somewhat prioritize her health care. So what we're finding now, what I've found in my clinical practice is 10, 15 years ago, there wasn't much talk about menopause, or it was just considered, even though some people say, "Oh, I need to go through this. It's my natural process. I'm going to go through it, and I don't really want any help." But a lot more women now are more, especially after they birth their children, grow their children, they are now nested egg, they are nested, empty nesters. They were more interested in sexual activity, their body form, how they sleep, how they meditate, how they grow into their old age. And it's now a much bigger issue out there. So that has been my experience. There has been a radical change in the last 10 to 15 years about menopause and how it is seen.
Without a doubt.
Makes a lot of sense. We're living long enough to experience it. We weren't living long enough to experience it before.
Right.
Wow. Yeah. Okay. So, we still do have the unfortunate situation, certainly in Jamaica, where, and I know this because my clients tell me that they will visit their gynecologist who will tell them things like, no, 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 that stuff is in your head. Like there's still this thought that the only symptom of menopause is hot flashes or night sweats. Now we know them to be the flagship symptoms, but there's so many other symptoms. So people are still going to their very well name branded, gynecologist to have a conversation about, I'm having these things happen to me, ringing in my ears, crawling on my skin, anxiety and panic and depression, things that I've never experienced before. The weight gain is just coming on, and the doctor is saying it's all in your head. Why is that still the case in Jamaica?
That's a very politically loaded question.
Ah!
I'm gonna walk through the raindrops because I have to be careful in
dance. Yes, dance.
I'm dancing. I'm gonna walk first. I can't dance very well. But
Okay.
Anyway, so what happened is, let's give an example of me. Let's use me as an example.
Okay.
So I went to medical school at 17. I'm finished at 22. I was a consultant by the time I was 30 as a gynecologist. So what has happened now is that if you're not trying to catch up with the changes that are occurring in medicine, you're going to become archaic. You're going to have the same training that you had 20 years ago. And I believe, again, I'm trying to be very politically correct here. I believe that's what is probably happening to the local medicine here, in that we're not trying to catch up. And even still, let's be honest, a lot of us practice the very exclusive FDA says. But remember, the FDA is always sometimes 10 years behind the experimental medicine. You understand? And it's a largely political, financial, highly charged association, as much as it is respected around the world. The FDA sometimes gets it wrong, or they're a decade behind what the standard practice should be. So just speaking for myself, what I found, my first foray into this world of bioidentical hormones was actually in a small city where I did pelvic reconstruction surgery courses in Brazil. And 10 years ago, I went down there, and there are 3 gynecologists who run the practice. They have a hospital, a female hospital. And I found, I'm going to say something and don't laugh. I found that the women's vagina that I saw were just extremely healthy looking, very moist, and they're all in their 50s and 60s. So I remember going to the guy and saying, don't take this the wrong way. I'm not, but why does it look this way? Because anatomically, it looks quite different from what I'm exposed to in our Caribbean women that I see every day. And he says, oh, you're not used to this yet? This is what we're doing. So in that town, right on the cusp of the Amazon, they were having identical hormones being inserted from 10 years ago.
You're giving me goosebumps,
I know.
Yeah. So when you see these Brazilian women, and they look so voluptuous and nice, and they were way ahead of the curve in terms. So my interest in bioidentical hormone therapy started from then. What bothered me, and as a personal experience again, is that I got roadblocks everywhere I tried to introduce it in Jamaica. There's a roadblock here, there's a roadblock there, there's a roadblock there. No, we can't do this. Or so eventually I was able to figure it out in terms of getting it available on a relatively steady availability to everybody for a reasonable price. Because the objective is not to hurt anybody. It's at a price where the average person can afford it on a monthly basis. If you cost it out as a monthly therapy.
Right.
So that is why I think what happens is that we are not traveling. We can't learn more than what we are exposed to.
Right.
Which is why we do what we do. This is why we're doing what we do, is to be gaining this awareness and have people talking about it.
Right.
Yeah. And let's not, we're not throwing anybody under the bus. However, it's not just a Jamaican doctor phenomenon, right? We do see when we look at social media, it's something that is significant in the United States. Big superpower of the US of A. And I would hazard to guess that most countries. So it's not just a Jamaican phenomenon. So can you tell us, a woman comes to you in your practice and is in her 40s or above, and is indicating that she's going through some things, and she's mentioning the kind of symptoms that we now know to be symptoms of perimenopause. At what stage do you start to have the conversation with her about treatment options?
So very good question. This conversation is always individualized. So that's another thing that I try and struggle with in speaking to my colleagues and some of my patients. What might be good for Nikki is not good for Natalie. And you're all at different life cycles. So the conversation is who should the conversation be had with? Any woman over age 40 who has symptoms of the climacteric, which we will discuss, or any woman under 40 who has premature ovarian failure, the conversation should be had. And the symptoms of the climacteric could include, as you had alluded to earlier, hot flashes, you have vasomotor symptoms, you have neurological symptoms, you have emotional symptoms, you have the vaginal dryness eventually, you have genitourinary symptoms. In fact, there's a patient of mine who happens to be on, I see her name, she gets UTIs ever so often. For there's no reason. She just gets a UTI, and it's frustrating for her. And it makes her life very difficult. So she's a person who I tried to introduce. You have to be careful again. That's when you're talking to women about bioidentical hormones, especially use the big word T, testosterone. I get really crazy. Like, oh my God, that's not for me. But yeah, I have to slowly write her 10 prescriptions for her UTI until I say, listen, we've been doing this, let's try this. Until eventually she broke and said, okay, I'm willing to try it. You understand? So you also have bioidentical hormone therapy used to prevent potential side effects down the road, such as osteoporosis, that will eventually happen and lead to your brittle bones and a breaking in your hands and your hips, and that has significant morbidity and mortality. So the discussion is had with anybody who comes in, and not only is it had, but we have a program that we use, and it urges me to ask the relevant questions. Do you have this? Do you have that? Do you have this? Are you willing to explore the necessary blood tests to see? Because remember, that's another important point I need to get out there. You never treat a result. When you do a blood test, it's a spot test at a particular day, time, and event. And it does not necessarily correlate with the symptoms that a patient has. So if you do a blood test and you see the estrogen at the lower level of normal, sometimes this estrogen band is this big. So you are at the higher end of the band, but when you're at the lower level of normal, you're not significantly under-operating. So sometimes, a lot of times, patients will come and you give them a result and they go, oh, but I'm normal. No, you're not. you're normal for that cohort, and that cohort includes white, black, Indians, Chinese, a lot of people who might not necessarily be a part of the race or the subgroup that you're from, or the kind of diet that you have that will affect how your testosterone, your estrogen levels, etc. So we have that conversation. I try to do it now with anybody who's over 40. Start to have a conversation.
Okay. And well, sorry, go ahead, Nikki. Go ahead.
No, I just have a question because you talked about the estrogen being normal. Of course, when we do these blood works, it says it's normal. You know, it's not out of range. Are we gaining awareness here in Jamaica to change those numbers so that, I mean, you're a professional at it, but they may go to a gynecologist as well. This is normal. You're within range, and then it dies there.
So Nikki, when I went to medical school, I think we had the greatest medical professors ever. And one of the things I was taught from very early that you never treat a result, you treat the symptom.
Right.
So not because you have a normal result. As I said, when you do a test might be done as a spot day for one moment in time. It does not tell you for the 24 hours or the 365 days of the year as to how, because remember, these hormones go up and they go down. So you might do it in a cycle when it's up and it comes across as normal. And then that's one. The second thing is why you can't use a spot result. As I say, you, Nikki, might be operating at a higher level of estrogen because that's what you were performing at. Another person might efficiently perform at a lower level of estrogen. However, when your estrogen falls to theirs, even within the normal range, you're dying. The hot flashes are killing you. So you never, ever, I don't know how to reteach that because that's how I was taught. Okay. You have to treat a patient, not a result. A symptom, not a result.
Symptoms, okay. Right. And what happens to the patients who don't have symptoms? Meaning, so you have a lot of women who don't have menopausal symptoms, but they are in the menopausal arena then, or journey. You still encourage them to come and have the conversation with you.
So Natalie made a very important point earlier when she spoke about the symptoms and not everybody having it. Remember, menopause encompasses not just the climacteric or the menopausal symptoms. Again, as I just said earlier, it also affects your genitourinary system. So you see these women and they say, oh my God, I'm peeing up myself, or I cough and I'm having a little bit of vaginal dryness and sex is uncomfortable, when it wasn't. So it doesn't necessarily have to encompass the hot flashes or the anxiety or the foggy memory or the lack of sleep. Also, as I alluded earlier, it also affects, you need to prevent osteoporosis, which is not a symptom, it's almost a preventative situation. So some women who come to you and they are at a higher risk of osteoporosis, you can put them on. They might not have the other symptoms, but you're doing it as a preventative thing to prevent bone fractures down the line. It also has its added positive effects to Nikki, such as on the heart, because it increases the risk of coronary artery disease. And also, it also prevents the risk of some strokes in some people. So you have to kind of taper it and look at it and look at each patient individually and see what am I trying to accomplish for this patient, because Nikki is different from Natalie.
Right. Dr. Rockhead, you've been using a word that we've not heard. I've not heard used before to refer to the onset of menopause. What is that word?
What, the climacteric?
Climacteric?
Oh, so the climacteric by definition is when, sorry, there's a background noise. Is by definition is the period between when you start to have the symptoms to when menopause has definitely starting, meaning you haven't seen, the ovarian follicles have died up. You're not having one more period, you're not seeing anything. So during that time of the climacteric, you might have periods as per usual, or they might be sparse, or they might be heavier. But that's a period that we call it between the first set of symptoms. Okay. I will try and type it in the chat.
Between the first set of symptoms and the actual 12 months without a period.
Absolutely, yeah.
Okay, all right, cool, thanks. See, always learning, always learning. Okay, so when you start to have these conversations and somebody is agreeing that yes, they would like to start to support hormones, right? There's the three main, obviously, ones that we're looking at. We're looking at estrogen, progesterone, and testosterone. We've spoken at length about testosterone pellets, right? What are some of the other, and by the way, testosterone is what saved my life. I'm a absolutely vibrant individual, you see me, right?
Absolutely, yes, I see.
They don't want to leave our couch.
Right.
Don't want to get up and do nothing. Wonders, why am I bothering? Like when I got to that stage, I was like, no, 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 no. Something is wrong. And then after about 2 weeks of having the pellet inserted, I'm sitting on said couch one day and I'm like, wow, I had an amazing week. Like I feel phenomenal. Like, and then I was like, what was different? And then I go back and I'm like, holy crow, that must be. And all of a sudden I felt like me again. So, and that's my little experience with the testosterone pellet. But what are the treatment options that you are using? What's available to women through your practice?
So that's an interesting conversation. I need to touch on testosterone a little bit because the way I use it might be slightly different from the way a lot of people do it. And I'm going to explain to you. So medicine is a largely is a business. We have to also remember that it is really a business, and it is a massive business anywhere in the world. What I do is I practice medicine. I try not to practice the business of medicine. There are two different things. So for you to understand where we are or what I do, I have to go in a little biochemistry, a little breakdown. It's going to be very simple, and you'll understand why I do what I do in my practice. So everything technically starts from cholesterol. Everything. All of your sex hormones, they start from cholesterol. And then when you ingest it, it's packaged and it's broken down into different sets of hormones. So it goes to in your brain that they call ACTH, the cortisol in the adrenal glands, and that's where your stress hormone and so on occur. Then it goes into another subgroup where it goes down into your sex hormones, and then you have the 21 carbons and the 19. So cholesterol is a 21 carbon, the amount of atoms, right? Then it breaks down into testosterone, which is like a 19, and then into estrogen and progesterone, right? Now, because of that, in my practice and how the Brazilians do it, and one of a breast cancer specialist who's female, who was one of the foregoers in testosterone therapy in women, especially in women with breast cancer. We don't really like giving estrogens unnecessarily. We try not to. And the reason for it not is that the testosterone is broken down in the fatty tissue in everybody into estrogen. So by the very nature of how it is metabolized, we rarely have to give it. I'm not saying we absolutely don't, because again, each person is individual. And some people will break down that testosterone enough to give you enough estrogen, and some people who are very active might just burn through it and you don't see it in the same.
Got it.
So my first choice.
What I'm understanding from what you're saying is that we will convert testosterone into estrogen.
Beautiful. Okay. Beautiful. And what we also learn is that testosterone, which in a different form when your ovaries are producing enough, is responsible for most of the vasomotor symptoms that are like the hot flashes and the memory loss and the cloudy memory and the emotional highs and lows that women get. So the testosterone also solves that problem. Okay. And it also solves the bone problem, the osteoporosis problem. So that's why it's such a potent drug in and of itself.
Gotcha.
We use bioidentical testosterone, which is is naturally occurring from wild yams, and they're able to extract it, and we deliver it as a subdermal injection, usually in the buttock in women and in the flank areas in men. Estrogens, on the other hand, no. We have transitioned from Premarin, that is an old-time drug, 0.625 milligrams.
From the horse urine, right?
Right. Premarin. That's where it comes from. It comes from the horse urine. Then we have moved to the So we have moved to the synthesized ones, which can be given either orally or transdermally. Transdermally is by the patch. I hardly use those. I find that the side effects are. I'm gonna explain. So here what happens. So let's deal with let's put the pellets aside. We're gonna go through the other traditional pharmacological agents, right?
Okay.
So in the woman who has her uterus in place, this is the worry we have. When your uterus is in place and you're in your menopause, the uterus is in quiescence, nothing is happening. If you start to add estrogen to it over a certain dose, particularly over 0.625 milligrams, you wake up the lining of that uterus, that it starts to proliferate. And in some women, they start to see bleeding or spotting again, right? And the danger of that is that if you have unopposed of any hormone without something preventing it can lead to some form of malignancy.
Okay.
So that is why most patients who have their uterus in place, they have to have a form of testosterone to be given with them. And in the old days, we used to use medroxyprogesterone, MPA, medroxyprogesterone, and that was associated, that we have clearly seen, with cancer of the breast in all of the studies. So that was the big drawback in going down that route. In the woman now who is now no uterus in place, you can give it unopposed because it's not for it to act on, right? The French came out and they started to switch the medroxyprogesterone, the MPA, to counter the estrogen to a more naturally occurring progesterone they call dihydrosterone. And they have found that it does not cause that same level of malignancy that is associated with breast cancer. These are options that are available for the patients who says, I don't want no testosterone, I don't want to be cut, I don't want to put anything under my skin, right? Those are the options that are available. I personally, I have it available in my armamentarium. I don't like using it. Right?
And how is that administered? I'm sorry, that's done.
Oh, good question. This is administered orally, and the progesterone sometimes vaginally. Right?
Okay.
A new therapy now that is being used now, Nikki, for women who have extreme vaginal dryness and they're sexually active and they don't want to go down that road that we're talking about, is a compounded medication we call DHEA. Dihydroepiandrosterone, that they put as a vaginal mix, and it has been shown to cause the vaginal mucosa to get pink and healthy, and it doesn't have any systemic side effects. Okay?
Before you move off of that, DHEA is also an over-the-counter available supplement. If taken that way, does it have that benefit as well?
Not the same side. Not the same side. That is that is now the basis of medicine you're talking about.
Right. Okay.
So it can be compounded in an appropriate way, in an appropriate medium, and then inserted as a vaginal cream.
Okay.
And it works extremely well. But it also, if we're going back to the biochemistry of cholesterol, when the cortisol works on the adrenal gland, this is very technical, a byproduct is DHEA, which has great effects on women in terms of how testosterone works. It has muscle building, prevents the hot flashes, etc., etc. but given in an oral form, there's a thing you call that first pass metabolism. When you ingest something and it goes to the liver and it's broken down, you don't necessarily control how the byproducts come out and what the deleterious effects of those byproducts are. So that's why a lot of those medications are better off in a topical or cream form.
Because it doesn't have to be metabolized in it.
Very good.
Got it.
Very good.
Got it. So awesome. This is such a great conversation. All right. So how long does a woman, if given the appropriate HRT or MRT, whatever you want to call it, for her symptoms, how long before we start to see an improvement? For example, I started to feel better after getting the testosterone, but my memory is still shot to hell. My kids tell me every day, Mom, you have the memory of a goldfish. When is my memory going to come back?
No, that's the same. That's the same way I say everyone has to be individualized in terms of how their therapy goes. And sometimes the first shot is just the means for your body to start responding in an appropriate way. And it might take a while.
Okay.
You know, it's not, we all want miracles. You know, I would love to have a miracle. I don't want to be at work today. I was working all day yesterday, but unfortunately, I have to be here. You know, so to add to the question also, you had put it in a list of questions that how long is largely dependent on the individual. Some patients, you can go on HRT forever. You can go on HRT for the bioidentical HRTs I'm talking about. That's my interest. You can go on HRTs for a couple of years. It all depends on what you want and how you want to feel. I have a sexually active 78-year-old female in my office, in my practice, who is an avid sports person, right? And she's on her HRT and she loves it. And she's been on it now for about, I think she got her second dose. She absolutely loves it. But then I also have 45 and 48-year-old women on it. So it all depends on the person and what their needs are and how they want to live.
It's a customized, from what I'm understanding with you, it is definitely a customized approach that when women are in that awareness, whether they're in their late 30s or their 40s. I just want to do a little recap. You know, they come and they have a conversation with you or their gynecologist, list out the symptoms, and then you start targeting each one. But just recap for me a little bit on the exact HRT method you said you had orally. So just give me a little synopsis so that the ladies know exactly what it is that you offer.
We all have, every gynecologist in Jamaica has the oral ones, which is the estradiol or the Pamarins or the vaginal progesterone. Well, I have progesterone vaginal cream. I don't think it's readily available in Jamaica, but I have to have it so that you don't have to take it orally at all. Or the patches. The patches is not as available as it used to be, because back in the day when when it became very popular, it was given in a dose, Nikki, which was over 50 micrograms per milliliter. And what they found was they started to get a large incidence of blood clotting, deep vein thrombosis, and pulmonary embolism. So it was pulled from the market. Then they had to re-engineer it and realize you have to give a much smaller dose. So because of the side effects that it had, some jurisdictions were a little bit cautious in reintroducing it into the market wholesale in a wholesale way, like everybody having it, if you get the point of it.
Yeah.
But on another note, though, and this is a passion that I share with you women, I feel that you women are underserved, and I believe that also you're your worst enemies, because if you push hard enough for these different options to be available, you know, we really wouldn't be having some of the difficulties that we're having. Sometimes I have to fight through different means to get certain things available to my patients because it's just not there.
Yeah.
It's just absolutely not there.
Yeah.
And if we look at the population of women that we have, I think 55% of the workforce is women in Jamaica. And most of the middle managers are women in Jamaica. I still believe, and I've said this repetitively, from from the point of view of the dollar spent on a man to a woman is about they get about a third to a half more money spent on their individual healthcare than for a man over a woman. But you guys contribute about 2/3 of the insurance fund to fund the whole insurance industry. So,
Right.
you know, I think it's something that Nikki and Natalie has to take up as a charge as to women and try and see if we can make a change. Coming from a man, it doesn't sound too right. You know, it's always gonna say I have an ulterior motive behind it. So that's why I'm pushing
No,
that.
I think no, and I think it's amazing that you brought that point up because it's something that Natalie and I have spoken about in the past with other providers that is the more people that talk about it, the more doctors that talk about it, male and female, is the more
Yep.
movement that can be made in the insurance industry and all of that so that it becomes available to the average Jamaican that they can go and afford to have their hormones tested and afford treatment. And this is why Natalie and I do what we do is not only about creating awareness about a menopause and it's happening in the workplace as well, but also to make it for the people to see that it has to become affordable for women. It has to be. That is the future.
True.
Yep. Okay. So I think that's amazing.
When a woman does go on HRT, you said that you've got this vibrant older woman. Why would a woman choose to come off it? And when I go on it, can I be on it for the rest of my life? And then what happens if I come off it? Do my symptoms return?
So the short answer, yes, your symptoms are going to return. The short answer, the first one, yes, you can go on it for as long as you want, unless there's a medical contraindication to its use.
Okay.
Yeah. Because as he said, Nats, you know, it's not only about just immediate hot flashes and stuff. We're talking about long-term effects, heart, kidneys, you know, osteoporosis, the brain, Alzheimer's, all of that. That's long-term preventative when you start off early, which I think is very important because a lot of women are saying, oh, I can deal with the hot flashes. I don't, you know, I can manage. But one of my reasons for going on HRT was that my blood pressure went from flatlining practically to 160, and I was like, what the heck is going on? And it turned out menopause, and that was my first intro, and to me that was what I consider the big boys, and that's why to me HRT is important for the big boys, your heart, your kidneys, you know, your brain. So I think that's
I must also introduce this though. I also, our office also has the testosterone cream that we give for some. There are some patients who just are absolutely against having anything inserted in them. I mean, I've been told that flat out. I don't want.
It's a real thing. I agree with you, Dr. Hood. It's a real thing.
Right. So we also provide the testosterone. Which I find this. I mean, I've seen it being used. The first time I saw it actually was, as I said, in Brazil. But it's a very untidy, you know, kind of way of using it. But we also offer it to some of the patients where they're you know, for whatever reasons, personal or otherwise, they don't want to have anything injected. So we offer that for the therapy also.
Okay, so that for testosterone, and you said you have you do patches as well for the estrogen?
No, the patches, no. We have to get some push from you guys and some women to get the Ministry of Health to release it up. Because every time we try and get it, we get a hard time. But the estrogen patches are available in the lower dose, which doesn't have the side effects of what we call thromboembolism, which is the deep vein thrombosis or the pulmonary embolism. But the truth is, Nikki, I'm more into the natural hormones than the synthetic hormones. I try to push more natural hormones as much as I can.
That is so important. The yam soy based the bioidentical hormone therapy.
Right.
I saw an article published recently showing that talking about weight gain now, right? And that dreaded midsection spread that said that it was a small study, women who went on semaglutides for weight loss, and women that were on HRT and went on semaglutides for weight loss. And the postmenopausal women that were on the semaglutide and the HRT had a statistically significant greater weight loss than women who are menopausal and only went on the semaglutide. Have you seen that study? And then my follow-up question is, will all weight loss programs be more effective in perimenopausal women who are on HRT versus who are not?
So let's answer that. I've not seen the study because usually I don't read studies until they're randomized control trials or cohorts or meta-analysis. Because early, so again, when you're in this thing, you realize that there's money behind everything. So I can design a study, not to say anything I want. But however, when you cohort, meaning you get a group of studies together and you reanalyze them and you redo the statistics, it gives you a different power of reading. Or when you meta-analyze it, which is like 20 studies together, you get a different power. But in answering the question in a very pointed way, it makes a lot of sense. And remember when we spoke about cholesterol at the beginning, and
yes,
cholesterol goes to ACTH, which goes to cortisol.
yes.
And cortisol, remember, cortisol is that stress hormone, right? So when your sex hormones start to fall, we're going back to some biochemistry again, first year medicine. When your sex hormones start to fall, the body is saying, my God, what's going on here? I need more, I need more, I need more. So it starts to push the body to produce more sex hormones, but at the same time, it's also producing more what? Cortisol. And the more cortisol you produce, the more your insulin rises, the more your insulin rises, the more you get insulin resistance, and the more you're going to put on weight. So that is why a lot of women, as they hit menopause, they start to get kind of, I don't want to use fat. That's not a nice word.
Their BMI starts to increase.
Yeah, no, the midsection, I like that one that you use. Yes, the midsection starts to get a little bit broader. But that's why it's really a scientific reason. It's not something that is in your head.
Right.
Because the body sees itself as trying to maintain a certain normalcy. And when it sees the normalcy changing, it's saying, my God, what's going on? I need to fix this.
Mm-hmm.
So in the process of trying to fix it creates other problems for itself. So it sees the sex hormones falling. Then it says to the body, listen, we need to convert more of this cholesterol into all the sex hormones, but it's drying up. But at the same time, a byproduct of that is that your cortisol levels rise. The cortisol leads to glucose production, which causes your insulin to rise, and your insulin causes you to pack on the pumps, especially in the midsection. So that's what happens. So now, in answering that study, if you now produce the sex hormones exogenously, meaning either, right? The body is saying, oh my God, I'm good. You can turn off this pipe up here.
Turn off the mechanism.
Right. You have less cortisol being produced, less what they call gluconeogenesis, which is glucose production, less therefore insulin. And guess what happens to you? Boom. You start to look like what Natalie looks in the gym.
Don't say that become my midsection.
Hey, Nikki, she don't wear the clothes in the gym with us, so I know.
I see her online. Don't worry. It's there online, but we all strive to be like that. Trust me.
Very hot in the gym. There's no AC.
That's the excuse she's using.
That's cute. But she takes that photo while she's in her AC in her closet dressing. So we know what the truth is. Dr. Rockhead, we have a question here because I really want to utilize all the time we have with you. We have a question. If with testosterone, would women start growing chest hair and facial hair like a man? Does it work like that?
All right, so those are side effects of testosterone, but every side effect is dose related in hormones, in the sex hormone industry. So we give you a dose. So there's no perfect way to calculate you, but what we use in our clinical setting, in our office at Ocean Amadeo, is we use 1 milligram per pound as your max. So if you're 100 pounds, like Nikki looks to be 100 pounds, the most you're gonna get is 100 milligrams, the most. And then we cut you about 70 to 75% of that. So you will never ever overburden the serum levels of testosterone. So it's not going to happen. It's just not going to happen.
So
And
you
then
kind of
remember
build
now,
up, you build up from there, or you always will stay at that.
no, very good. Remember now, it's individualized. So it depends on how you react to things. We might have to tweak you a little bit up or even down. We're not sure what's going to happen.
Okay. Okay. That's good. Okay. And the next question is, heard the cons reusing estrogen with intact uterus. What are the cons using estrogen if you have had an OVH? I'm guessing.
I don't know what the OVH is.
What is an OVH?
Maybe an ovarian hysterectomy.
Jimmy, must be Trudy. I know you were the one who asked that. Maybe Trudy, you could share with us.
Yes. Hi, everybody. Yeah. That's my short for ovarian hysterectomy.
Okay.
So you don't have all right, so let me just clarify that truth. You don't have an ovarian hysterectomy, you have a hysterectomy. So the ovary and the uterus are two different organs. So either hysterectomy or oophorectomy. So an oophorectomy of any types, once removed, you're immediately menopausal. So in a person like that, it behooves them to be on some form of hormone replacement therapy. And there will be no side effect if the ovary is removed. The uterus is left behind. Once the uterus is left behind, whether it be a chemical castration by chemotherapy or a natural castration by the menopause or a surgical castration as in surgery, we have to be mindful of the effect of what estrogen has on the uterus, unopposed.
Okay, so if you have no uterus,
right,
what would the effects look like?
It won't have an effect at all in anything on the reproductive tract.
So the possibility of breast cancer is not as great?
No, well, so the breast cancer is a different organ. So
I know, but you said that if you have uterus intact and you used estrogen, then your possibility of one of the side effects or one of the cons is that you might get breast cancer, or your risk for breast cancer might increase.
No, so what we're trying to delineate very previously, estrogen by itself in the appropriate doses is not associated by all the many women studies, etc., would not increase risk of breast cancer. What we, however, said, when you use estrogen with a particular progesterone, especially when it's given orally, hydroxyprogesterone, it has been shown to have a significant increased risk of breast cancer.
Okay, so the progesterone that is doing that.
Right.
Okay.
A specific progesterone and a specific estrogen.
A specific progesterone.
Okay. Does that help you, Trudy?
Yes, it's clarified. Thank you very much.
Great. Awesome. Quickly before we go, because I have another question. Back to the testosterone. How long does the testosterone, you give a dose of testosterone, how long does that last? Like how often do the ladies have to go back and be re-administered?
Individualized, usually between 4 to 6 months. But in the persons who hang out in hot gyms with no clothes on, it might be shorter.
Okay, Natalie.
Yep. Burn through it.
Okay, Michelle had a question. Will Ozempic assist with weight loss or controlling cortisol production?
No, cortisol production. So Ozempic is a GLP-1 drug. The mechanism of action is different. What it actually does is helps the cells, particularly patients who are insulin resistant, to use the insulin in a more efficient way, and therefore it reduces the circulating insulin around, and thus you lose weight. Because in the past, when I went to medical school, it was thought that insulin was just to control glucose. Now the whole thing has flipped on its head. We're now seeing insulin as a growth hormone. So it does more than just control glucose in the cells. It also is a growth hormone. So that's how Ozempic works. Ozempic works by telling the cells, listen, use this thing more efficiently, and therefore I can reduce my production of insulin from the pancreas, and therefore everything will work out a lot better. So that's how it really works. Okay. So gotcha. Cortisol production now is an entirely different route in how the hormones work.
Okay. Michelle has a question.
So to go back to a menopausal menopausal woman who is not experiencing debilitating symptoms. So she's not feeling any way different, right? Would you still consider having a conversation about HRT because of the bone protection, the memory protection, the heart protection? So in an asymptomatic woman, we still should be having a conversation, yeah?
Very good. I mean, that's like top tier. I open the conversation to anybody who reaches about 45 years old. I don't.
Okay.
I still. I mean, it might not mean that they have any symptoms, no, but you increase the level of awareness as to what may happen and what will happen. And so probably 2 or 3 years on the line, that patient might see value in coming back for that specific issue. But the conversation should be had. You know, I mean, as I said earlier, when we just started the program, menopause, no. A woman's lifespan has added 30 to 35 years to her life. So we can't just lock you guys away in a house and say, yo, to eat some, prepare some meals and some clothes. It's not the same as 100 years ago. So we have to give you
thank God
quality of life, that needs for the next 30 years. You have to live your fullest life. You can't live a life which is, So we have the conversation. We try to have the conversation.
Because the HRT is against all those things.
This is what Natalie and I tell all the ladies that listen to our program: have the conversation, have the discussion with your doctors to figure out where you're at. And I think it would be a good way for us to segue a little bit into men. Now, this is a very important topic as how men are involved in this. Now, you talked about you do HRT for men as well, but the education of men on this journey for women in menopause, in my eyes, is crucial. So how do we increase that knowledge? How do we empower our women to get our men involved in the discussion? Or how do you empower the men that come and speak to you or come to talk to you about HRT? If they do, I don't know. This is a two-person job.
So I find that women are very good in convincing males to do whatever they want to do. That's just my opinion. But on a serious note, Nikki, what I try to do in my office, I find when a couple comes to me, is a much better conversation and a much better and a much better buy-in. So I try as much. Sometimes a patient will come in my office. I'm in the office now, and she's here, and the husband or consort is outside. And I said to them, no, go for them. Let's talk. Because whether I want to believe it, yes or no, we're different and we think different and we ask different questions. And so sometimes why the woman gets a hard time is she comes and she asks certain questions which are a tad more emotional, or how is this going to happen? And I'm going to ask more practical questions like, what's the biochemistry of this? How does that affect that? And so when she goes and she says, Doc, say I must do this, and I say, okay, explain to me why. She can explain it in her language, but not in the language that will lead to the buying on his side. And that's the problem. It's not that they're difficult people. I mean, men are not necessarily difficult people. We just think absolutely different.
Yeah.
I mean, being a man brought up in a house with a lot of women, I can tell you I lived that every bloody day when I was growing up. I saw it one way, and we're looking at the same outcome, but the journey is absolutely different. So the buy-in now is to say, yo, take your consult, your husband, your significant other to the doctor.
I love that.
I think that's a great recommendation. Doc, what's the window after last period where a woman can safely consider going on HRT?
There's no window, but you get better results the earlier you start.
Okay. Okay.
You get better results the earlier you start. But there's no, like I said, my 78-year-old who has a 52-year-old boyfriend.
Wicked.
Yeah, man.
We should all strive for that.
she
Unmarried ones, Nikki.
she bought into it. She bought into it 20 something years late. But I mean, you know, you're using it, so you have to take care of it. I mean, as much as you can.
And
Gotcha.
start from early. Starting from early. This is the key, is to starting from early, having that conversation and knowing that there are options available and having that discussion with your. A lot of women don't want to talk about it. They're, you know, taboo and all of these other things, but it is important that the more awareness and the more discussion that happens is the more movement we can get on this journey.
Nikki, let me say something on that topic. There's a Caribbean phenomenon. I think it's Caribbean because when I travel, I don't get the same. You know, people just step out of a clinic and they talk to people, oh, I just got my shot and I'm good. Or, you know, I got my testosterone, and they talk openly about sex. And a lot of things are very taboo in the Caribbean household. So I think that's what is holding back how this thing proliferates or becomes the norm. Because right now, you're talking about men. I mean, we happen to have a pharmaceutical company that we use. We have an investment in it. I've brought in, for instance, from some of the guys who were trying to put the testosterone on, 5 milligram Cialis, and I was saying to one of them in front of the wife, oh, you know, he got testosterone. And he but then a man takes 10 times the testosterone a woman has, and therefore it has other, you know, not side effects, but there are clinical changes that happens in a man's life, you know, such as his blood count goes up, and if his blood count goes up, the blood gets thicker to pump, so it can potentially cause a slight increase in his blood pressure. So the Cialis, which was originally a nitrous oxide inhibitor from way back when. That's what it was used for until they realized it was causing a rise somewhere else, and then they marketed it as a you know, a sex drug. And when I said to him in front of his wife, you know, as a part of your treatment, I give you the 5% Cialis for free. It's like as a part of the whole. She said, no. He doesn't need that. He doesn't need that. It's crazy. And so it's a taboo. We're not willing, and these are fairly educated people. We're not willing to have the conversation about the science. You know, we're very TikTok-y, Facebook, Instagram, where the science doesn't matter, it's opinion. And so that is some of the challenge I pose in it proliferating, even in, because you'll go out with guys who you have done it on, and they're telling you, wow, you know, I've lost 15 pounds or 20 pounds and I feel good and I'm sleeping well. But them have them brethren right beside them who's suffering, and they're not going to tell them.
No.
And, you know, they're getting ripped and they're looking good, but they're not saying a damn thing. So, so again, it's a taboo. It's how we are as a Caribbean people. You know, we tend to internalize a lot. We don't want to talk about anything. And that's why this program is so important, you know, to happen, because the awareness, at least you can tell other people that, you know, they can be helped somewhat. Yep.
Wow, this has been an absolutely, oh, we have a quick question here. What fills the empty space after hysterectomy, and is a pap smear still necessary?
Good question. The second one is a great question. The first one is just bubble. Because remember, there are feet up and feet up and feet up and feet up bubble. And the uterus, when the uterus, I can't really get up, but there's a little scale. The uterus is about this big. It's not very big. So there's not like, there's a big gaping space up there.
Got it. Okay.
Pap smears. A pap smear is necessary on a hysterectomized woman if she's had a previous abnormal pap smear, such as anything signifying any form of HPV disease. Okay. Because there is such a thing they call vaginal intraepithelial lesions, which can be precancerous vaginal lesions. So they should do it at least once a year or once every 2 years. You know what office we do once every 2 years because we do thin prep. But you should have surveillance going on. If you have had any abnormal pap smear showing HPV, you should have surveillance until.
Okay.
Okay.
Okay. For the ladies who, or gentlemen, I'm not sure who's in the audience today, if you joined late or there has been amazing information here. We have started up a YouTube channel where we are posting the replays. So in addition to Nikki sending out, when Nikki sends out our wrapping up email for anybody who registered, you can access the replay in one of two ways, whether on our Google Drive, where you'll have a repository of all previous episodes, and also the YouTube channel, which we are taking our time to build up the repository. It's been quite a few, so we still have 30 to go. Can your cervix be removed with your uterus? Is a question that Trudy is asking.
So yes, truly the hysterectomy can be done as a total hysterectomy where the cervix is removed, or it can be done as a subtotal hysterectomy where the cervix remains.
All right, so my next question is going to be, is a pap smear still necessary with a total hysterectomy?
So as I alluded to that earlier, if you have had a abnormal pap smear at some point in time showing any form of HPV, it is necessary that you do a pap smear or a thin prep once a year or once every 2 years.
Okay, thank you.
All right. Well, this has been amazing. I think that the conversations have been, I think we almost need to do a part 2 of this because there's so much information. But what is important for us all to, small takeaway here, is that we do have options. They are available. It is important that you have discussions with your doctor. Things are not feeling right, you don't feel well, or just have a general conversation. Is how can I protect myself going forward? Maybe I'm not in it now, maybe I don't know. How can I protect myself going forward through whatever means, and get the ball rolling and have the conversation. Ladies, talk to your spouses, talk to your friends, talk to your church sisters, whoever it is, have the conversation, because the more that we do this is the more movement and power that we give to ourselves on this journey of menopause, which is a beautiful rebirthing experience.
I would like to say the journey of life.
There you go, even better.
All right.
Yep. Awesome.
I have thoroughly enjoyed this conversation, and you taking out so much time out of your very busy day, Dr. Rockhead. How do people find you? And we will send this information out as well, but how do people find you if they want to sit down in a session with you?
Well, my office, my nurse's number is 876-428-5504.
876-428-5504.
Yes, that's it.
Okay.
And you have my social media handle because I'd sent it to you earlier.
Yes.
Right, so you can post that.
Okay, awesome. Well, you are available, and you will have a lot of ladies coming knocking. Hopefully they'll bring their men with them, and this is going to be a good movement. So thank you so much, Dr. Rockhead. I so appreciate you spending the time with us here today. This has been amazing.
Okay, Nikki, thanks for having me.
All righty, guys. Everybody have a wonderful rest of your day and your week.
Thanks.
All righty. Bye-bye.